Professor Dame Anna Dominiczak, who came all the way from Glasgow to be here with us today. Professor Dominiczak is the Chief Scientist for Health for the Scottish Government and Regius Professor of Medicine at the University of Glasgow. She is globally recognized cardiovascular scientist. Her research focuses on hypertension, cardiovascular genomics, and precision medicine with over 500 publications. She played a key role in establishing the university's clinical academic campus at Queen Elizabeth University Hospital in Glasgow. Professor Dominiczak also led the UK Lighthouse Laboratories during the COVID-19 pandemic. She's a member of several editorial boards. She was editor-in-chief of Hypertension, Journal of the American Heart Association, and currently she is editor-in-chief of Precision Medicine, a new PRISM journal of the Cambridge Press. Professor Dominiczak now works to accelerate innovation in the Scottish NHS by fostering collaboration between academia, the NHS and industry. Please welcome Professor Dame Anna Dominiczak.
Dziękuję bardzo i ja tak z prowincji, więc bardzo się cieszę, że Państwo mnie tutaj zaprosili. Bardzo dziękuję. Now let's go for English. It's so much better for medicine. Sorry for this. So, precision medicine in hypertension is the topic I'm really interested in, and I would like very briefly to describe why. Starting with this, you would be surprised if you haven't seen it that WHO report post-COVID, a little more than a year ago, said that we really have now pandemic of hypertension and cardiovascular disease, and we really do. We see that patients, even in Western economies, stopped going to the doctor, stopped taking tablets, and disease is proliferating. And of course, if you look at Africa and global south, people are not even diagnosed and treatment is nowhere there. So it is still the problem, despite years of fantastic research and many randomized clinical trials. We thought we solved it. Well, we didn't. And I think the way to solve it, or at least improve it, lies partially in genomics. You might be surprised. Yes, we have hundreds of drugs. Why is she needing genes? Well, I do, and I'll try to persuade you that that might be a good idea. So, first of all, this nice round diagram shows genomic architecture of blood pressure. There is 20 years of research that is summarized on this one picture. You'll see it bigger in a minute, but monogenic single gene hypertension, we have now identified 30 genes across the world. And this is where there is genetic mutation. We understand entire pathophysiology, young people, children, adolescents, very severe hypertension, and the treatment is very precise because understanding the mechanism leads to the right treatment for this. But these are very rare, as we all know. The majority of patients, I and many of you would see in clinics, suffer from so-called polygenic or primary hypertension, many genes, maybe thousands, we don't know. But studies that our group in Glasgow and many others around the world participated in did show this genome-wide association studies showed thousands of markers. These are markers, single nucleotide polymorphisms with very strong association with the phenotype. Each gives tiny little contribution, a few millimeters or even less of blood pressure difference, but if you combine them all, if you unlucky inherit from your both parents all the bad ones, then this difference is large. So the big red dots, these are monogenic syndromes. They named here. We know how to treat them. But thousands of dots that are green, blue in here. This in 2021, when we published this paper, there were nearly 1,500 of those. Now there are more. Yeah? Could we use them to help patients to stratify, to truly treat according to, a bit like our colleagues in oncology, to stratify and treat the way people need to be treated? So this is an example of most recent genome-wide association study published earlier this year. Many groups, including ours, 100 authors. People always laughed at us that there are more authors than genes discovered in cardiovascular medicine, but that's not true. We're getting there, you'll see in a minute. And look at this p-values. This is negative logarithm, so p minus 200 very frequently. So this is not random findings, this is real. Now, this is the same circular picture that we really like. It is now bigger, and you can see that if you add cleverly, using Bayesian statistics, all the little dots, the ones in greenish, bluish colors, you can use it to treat before disease develops. These are so-called polygenic risk scores. We have learned to use the SNPs, thousands of them. You've noted, I should have told you, it's not for 1,500, now we have more than 2,000, and more are coming every time a paper is published, yeah? We can add all this cleverly and see whether we can predict risk, not only of hypertension, but of course cardiovascular events, strokes, myocardial infarction. And that's what we're all trying to do. So first, you see here in the same recent paper, deciles of risk of hypertension, both systolic and diastolic on this side, and a qualitative trait, yes or no, on this side. And you can see that whether you in the least risk group or the biggest risk group on this side, the difference is huge, very steep. We know that hypertension goes up with age. If you start at such trajectory in that group, you will have cardiovascular events, and this can be used clinically. And here it is. This is a paper published just a few weeks ago by Professor Nilesh Samani, close colleague from Leicester in England, who did a fabulous study, I believe. He used the NHS health check on thousands of people. You know about NHS health checks. Unfortunately, they're no longer done in Scotland, but that's a separate issue. So people at risk go have their blood pressure, cholesterol checked. He managed to gather more than 44,000 of these people. He observed them, and he had cases and very well matched propensity match controls. And what he showed is that the normal cardiovascular risk that we use, which is Q risk 2, that's what we are told to use, I think, across Europe at the moment. This is the European Society of Cardiology recommendations. You can do better if on top of this you add genetic information. And if you look on this side, this is really the most important. Here is Q risk in all cases he observed, and below in younger people, 40 to 54. That's younger for cardiovascular disease. So 40 to 54. In this group, your genomic information gives even more information about the risk of individuals, because of course we know that in cardiovascular disease this is always a combination of genes and environment. The younger the people, the more the genes still lead the way and environment still is governing. So nearly 40%, nearly 50% relative increase in identifying people at risk and being able to start very early intervention, in prevention, in the community, not in the hospital when a mild stroke already happened. Now, can we do it? Well, they can do it in Estonia. Nobody as yet has done it in this country, I'm afraid. In Estonia, this is published data 2 years ago, 3 visits, the patient and the doctor are given this polygenic risk score, this genetic information. And we see that after 12 months, their cardiovascular risk is significantly down, and it's also evident that they take more drugs, they fill the prescriptions for blood pressure tablets, for statins, they lower their cholesterol, they also do more exercise, their whole lifestyle has changed, and it's only 12 months, 3 visits, really cheap. Why aren't we doing this? Right, so that was prevention. We hear a lot, I'm sure you all read Lord Darcy's report, yes? From hospital to community, all this stuff. That's good, but lots of people already have disease that needs treatment. Can we treat better? Why all these billions of people poorly treated after all these years? Well, this is a short summary why. First of all, because this is a complex multifactorial disease, we have learned over the years that we need to do a randomized clinical trial. And once a drug works in randomized clinical trial, it goes to guidelines. And we write guidelines, I'm guilty as charged. We write guidelines to give the same treatment to everybody. Whether this is a young person with clearly stress-induced sympathetic overactivity, or 80-year-old with huge pulse pressure, high systolic, low diastolic, completely different stiff arteries, and yet we give everybody the same drug combination because guidelines tell us to give everybody the same. The time has come to think again, I think. There's a nice study in JAMA here that confirms this suggestion. This was without genes, simply phenotyping, normal phenotyping of patients. If you personalize, and we won't go into detail how they did it, there is 4.4 millimeter difference of blood pressure results. You'll see what does it matter. Even 1 millimeter mercury at population level in prevention or treatment reduces number of strokes by millions or myocardial infarctions by millions around the world. So it is worth it. But we can do better because we can use genomics and better biomarkers than just phenotyping. And this is our favorite biomarker called uromodulin, extremely interesting gene and protein that we discovered through GWAS, Genome-Wide Association study, more than 10 years ago. We and others have done a lot of functional studies, both in animal models and human functional studies. And we now know that this gene and protein are involved very closely in blood pressure regulation through this transporter in the TAL, in the nephron, NKCC2, sodium-potassium chloride cotransporter, responsible for 30% of sodium reabsorption in the kidney. So you can imagine that if you have a change in this gene, you can stratify people. From this work came a hypothesis, our own hypothesis, that we can divide people into high uromodulin and low uromodulin hypertension using just one marker, one of the SNPs, sitting in the promoter region of the gene, so functionally important. And you see here that these subpopulations differ. My AA genotype, 67% in Caucasians and not very much different in other ethnicities, is different. It's different, and perhaps we can do something in the clinic. So if I have people, I tried other drugs and they're still uncontrolled, we can use genotype-guided algorithm to determine whether we can give them loop diuretic. You know why loop diuretic? In this place of the kidney, that transporter is the main functional place for furosemide and all other loop diuretics. So we designed a study. It took a while to do it right, and it's just been published, and it's really nice when your hypothesis proves correct. So what we showed was that this AA subgroup responded much better to furosemide, which is identical to furosemide. It just was used because this was reusing of the forgotten drug. That was another thing. British Heart Foundation funded this study, just been published. The difference in blood pressure, again, systolic of about 4.6, nearly 5 millimeters mercury. This matters in patients in clinic, but also in population. There are other ways to use genomics to treat patients differently, and this is one example. The RNA interference, not as mighty as we see in vaccines and cancer, but this particular drug, zilebesiran, which is now in phase 3, two phase 3 trials, but this is phase 2 I'm showing you that is published. 90% reduction of angiotensinogen, the peptide hugely important in the renin-angiotensin system. It inhibits enough to lower blood pressure for 6 months, very profoundly, but not too much. The patient still would respond to, for example, septic shock or loss of blood. There's enough renin-angiotensin system left to respond. Very clever drug. And there are other similar ones, but only in mouse models. And last but not least, our American colleagues, Professor Victor Zhao and his team, published this study a number of years ago, and there's been no follow-up. This is animal model, CRISPR-Cas9, again, reduction of angiotensinogen, about the same 90%, but blood pressure stays down for a year. Now, a year in a rat's life, some of you would know, is probably 10 or more in human life. So we're coming towards cure of chronic disease that normally is progressive, but nobody tried and will not be allowed to do it in humans at the moment. So I'm there. I want to remind you that as we speak today, hypertension is controlled in less than 1/5 of patients worldwide. That's not very, very good. We've learned a lot. You see, for every drug even discovered 30, 40 years ago, we now understand molecular mechanism, but only the ones at the top, as I showed you, are really genomically discovered. We have done pathogenesis and pathophysiology first and drug next rather than guessing. We need to understand all these monogenic syndromes. There is no excuse not to diagnose them in young people with very severe disease and strong family history. But on the right, in red, we have only 2 markers, such as uromodulin, where a lot of work and functional studies have been done, and where we can stratify. We need more, and there is a lot of work to do on the red-hand side. And we need to do it because from 1.3 billion in 2023, we're now at 1.5 billion, not a very good number. So I just wanted to acknowledge colleagues and funders, and I no longer go to the laboratory and do the work. These are the people who really do the work, but they're wonderful, and I have 3 professors I brought from PhD in Glasgow, from PhD to professorship, so maybe I can join some of this mentorship. Thank you.
very, very interesting talk. I would like to present you with the little book, which I found kind of interesting. Any questions from the audience?
You're dealing with a huge amount of little data. Have you, well you probably have already, but have you started to use AI for analysis? And,
Yes.
And where do you think it leading to?
Yeah. So, yes. So the question was about AI. Absolutely. So this is the next step for everything we do. At the moment, my AI experience is with imaging mostly, but that lends itself also. If you have an algorithm, absolutely, yeah. So if you have an algorithm in which you want to use more than one marker and stratify patients, that would be the next step. The fantastic AI work we're doing currently in Scotland is in cancer. So AI to diagnose lung cancer better than human can, with radiologists, not instead of, but with radiologists, but really, shortening time to treatment, and the same with mammograms. Absolutely fabulous work. But it's coming to everything.
Are you looking with the hands-on data, or are you looking at publishing the algorithms which are shared between different bases?
I think what's happening at the moment is we're trying to evaluate this work. This is the imaging work, in order to adopt at scale in all. We have health boards, as you know, in Scotland, bigger bodies, not individual trusts. We would like to, if the money allows, to adopt at scale everywhere, and the sort of number is 90% of hospitals, 90% of patients should benefit from your technology.
How's the number?
Yeah.
I'll come to you in a second.
Brilliant talk, thank you very much, and really fascinating stuff. This is a question from a pediatrician. So, looking at your multi-genetic causes of hypertension, I see masses of children presenting with obesity, and something that's come through with type 2 diabetes. What about your work on methylation of DNA and then permanent changes? We know that these children will be living 20 years less, and the work in relation to hypertension and diabetes.
Yeah, this is huge. So there are now genome scans on methylation, just started being published. There is work like that being done. For example, you're probably aware of the 5 million people being recruited in a study called Our Future Health. This is UK-wide study. England was first. We just started recruiting in Scotland. This is a fabulous material where DNA is stored on every individual. They can be recalled and looked at. I think obesity, I didn't have the time, but really obesity is much more important than everything else. We see these children with hypertension that has nothing to do with monogenic symptom. This is simply secondary to obesity. I have a slide with obesity being a trunk of the tree from which all chronic diseases come. But I think the big question is, are the new drugs, the new anti-obesity drugs that government talks a lot about, we shouldn't politicize this because it might actually work. Not for children, I don't think, but for young people, maybe 18 plus, because we're setting them, as you said, we're setting them out for terrible life. Could we prevent earlier before things start going really badly?
Thank you very much. I admire scientific research, Professor Dominiczak, especially as I'm from Scotland as well. And I have just this very simple practical questions. When treating hypertension, we are always curious about the compliance of our patients, how they are taking the drugs, do they control the hypertension, blood pressure. And now I have this smartwatch.
Yeah.
It measures every 10 minutes my blood pressure, may I trust in it and think I'm safe, that it is okay? Of course, I have my treatment. It's a big jump from pediatry to geriatry.
Very good. That's a fantastic question. So hypertension experts believe that you need to measure blood pressure on your arm. And there is an enormous amount of research proving why and how bad it is to measure it on the wrist, etc. However, the wrist is great for heart rate, of course. And you know that you can diagnose atrial fibrillation and refer and treat. So there are good things about the watch, but not blood pressure. I wouldn't trust it quite. I think you're absolutely right. This is all, in modern life, the patient almost will treat or diagnose himself and herself, yeah? We need to give data, AI, ability to interact sort of almost without a doctor. One of my colleagues, who is currently a medical director of the British Heart Foundation, said the other day, we were on a round panel, said that we need to take prevention away from doctors to some other professions because doctors don't do it well. It might be right.
Last question, Paweł. You didn't want So if there are no more questions, thank you very much for fascinating. If you have more questions, we have plenty of time after we finish the formal part of our dinner to talk to our presenters. So please, do if you have more questions. Our last presenter is Professor